We'll move on to the next lecture. Dr. Pankaj Dougall, Nuclear Scan, What Scan in 2025.
Okay, good afternoon, everybody. So, nuclear scan, what scan in 2025? Myocardial perfusion imaging has been there for good 40 years plus. I've been practicing it for last 40 years. It has been there even before me. But a lot of new exciting things are happening, and nuclear imaging is such that it can not only measure function, perfusion, metabolism, we can look at infarcts, we can look at infection, inflammation, and even myocardial receptors. So what I have highlighted here is I'm going to talk what we are actually doing in current practice in 2025. Of course, there are other things like atherosclerotic imaging, apoptosis imaging, stem cell therapy imaging, which are still not routinely practiced, so I'm not going to talk about that. Now, what are the nuclear techniques which are available? Gated myocardial perfusion imaging, the so-called gated SPECT, what is so famously known as stress thallium, constitutes more than 90% of the workload in any nuclear cardiology setting. And out of gated myocardial perfusion imaging, thallium used to be the preferred agent till about 15-20 years back. Now it is replaced with other agents like sestamib and tetraphosphamine, which are much better in terms of image characteristics. And you can even calculate ejection fraction, wall motion, and so many other things using these agents. We all know that PET has a huge role in viability assessment, and of course there has been comparisons between MR with the PET CT and with the stress echo in assessment of myocardial viability. Then the recent there has been a stress on cardiac amyloidosis, the PYP scan. We routinely do it in our hospital. Then cardiac sarcoidosis is another area which has come up in a big way, and nuclear techniques have a big role. And then also PET CT for infection imaging is very routinely done. So now there are two kinds of systems we have, SPECT and PET. What I described earlier were the sestamib, thallium were SPECT tracers, and PET tracer, there are ammonia, rubidium, which are unfortunately not available with us in our country as of now because it needs an on-site cyclotron. Now coming to the gated myocardial perfusion imaging, which is the workhorse of any nuclear cardiology setting. Where is it used? For diagnosis of coronary artery disease, assessment of functional importance of known coronary stenosis. I think this is one of the main indications. Assessment of therapeutic benefits, risk stratification, assessment of myocardial viability. For that, it is used in a big way. Now, just to look at a quickly, very few examples. So, this was a patient who had a strong positive TMT. He had atypical chest pain, and he underwent a coronary angiogram, and which showed non-critical CAD. 7 years down the line, again TMT was repeated. It was still strongly positive, and stress myocardial perfusion imaging was asked for, and it was completely normal at a good workload. Similarly, there's a patient, 82-year-old male with atypical chest pain. The TMT was negative, but we decided to do a stress thallium, and as you can see, I'm not able to move the cursor, but there is a severe defect in the anterior wall, and which reverses at rest, which means that there was moderate to severe ischemia in the LAD territory, and sure enough, this patient had a proximal 90% block. See, when CT coronary angiography came we were told that myocardial perfusion imaging is going to get wiped out. In fact, it happened the other way around. Our workload increased because you have a high calcium score, you have borderline lesions, you don't know what to do with them. Would you like to go and do a coronary angiogram straight away? So this is where myocardial perfusion imaging again helps. In this particular case, a 58-year-old male, CT angio showed a 70% lesion in the right coronary artery. Calcium score was 450, but at a good workload, the myocardial perfusion imaging was normal. We also use it often for assessment of therapeutic benefits, like after an angioplasty. In this particular case, there is a tight stenosis in the LAD territory, and you can see there's a huge perfusion defect on the stress thallium. Post PTCA, the angiogram was repeated, and it shows good flow, and so does the myocardial perfusion imaging. Another big area is viability assessment. If there is regional wall motion abnormality, there is dysfunction post MI, post acute coronary syndrome, leads to depressed LV function and heart failure. And you often want to know whether there is viable tissue or not. So here what we do is the FDG PET. It combines perfusion image and a metabolic image. As you can see, the arrows are showing that there is a perfusion defect in the lateral wall, and on the metabolic image there is good amount of metabolism there. So this is what we call perfusion metabolism mismatch, and this is likely to improve. On the other hand, there is a fixed perfusion defect, there is a fixed metabolic defect. This segment is not likely to improve. Now, if we compare other modalities, mainly with dobutamine stress echo, the sensitivity is much higher, specificity is a little lower, but again, it depends on the clinical setting. How good is the echocardiographer? How good is the nuclear lab? So one or the other can be done, but it still remains the gold standard for viability assessment. Now, coming to sarcoidosis, of late there has been a lot of interest in this. Without going into the flow chart, this I have just shown that now it is embedded in the clinical protocol. You have a clinical suspicion of sarcoidosis, you do an MRI. If the MRI is either normal or equivocal or inconclusive, then a cardiac PET CT is asked for, and if it is positive, then it confirms sarcoidosis. If it is inconclusive, then you look for systemic sarcoidosis, where again a PET is very important. This is just to tell you the protocol. You do a perfusion image and you do an inflammation image. Inflammation image is nothing but a metabolic image which picks up. Because of interest of time, I'll rush through these. As you can see in this is a PET CT image. That colored blob that you see, that's where the inflammation is because of sarcoid. This is another patient where in addition to cardiac sarcoidosis, there was systemic involvement, and you can see there is uptake in the lungs and in the nodes. This is also very good for response assessment in sarcoidosis. In case of a good response, the green part of the slides, if you see, the first image is baseline image where you see there's uptake in the mediastinum, and below is the myocardial image which is showing inflammation, and after treatment it is all gone. So very good for response assessment. Another area which is into a lot of focus these days is cardiac amyloidosis, and again nuclear imaging has a huge role. We do what is called a technetium pyrophosphate scan, and I'll just come to the example straight away. So this, you see on the top, a bone agent called technetium PYP is injected, and you see there is a good uptake in the myocardium, and that is positive for ATTR uh, cardiac amyloidosis. As opposed to the lower segment, here see there is no uptake in the heart, and this is negative for ATTR CM. And there are various criteria, interpretation criteria, I won't go into them. Another area is cardiac innervation imaging. Now, this is important in patients of heart failure. If there are adrenergic receptors, and when we inject an agent called MIBG, if there is good uptake, that means the cardiac innervation is preserved. In cases there is poor uptake, these patients are likely to go into heart failure, and they have increased propensity for ischemias. Another very important area is infection imaging. Here you see there is a pacemaker. This patient was having fever and wanted to know if there is any infection. And as you can see, there is uptake in the pacemaker side as well as in the lead of the pacemaker. So this confirmed the infection. This is a patient with aortic prosthetic valve endocarditis, and you can see it's so easy to diagnose when we inject this agent FDG and we take the images. You can see there is concentration around the prosthetic valve, aortic prosthetic. Another area is to diagnose vasculitis, to see the extent and also the response assessment. Again, this is a quite often used, and it and not only tells the extent, it also can give us if the patient has responded to therapy or not. Thank you.
Thank you. Thank you, Dr. Pankaj, on that talk. And